growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here, and welcome to another episode of The Lionhearted. By the way, for those of you maybe tuning in for the first time ever, do you know why I call it The Lionhearted? Lions are a symbol universally of strength, ferocity, powerful. They don't quit, they don't give up easy. And that's what I hope the Lionhearted podcast and its followers understand, that's what the name represents, because dentistry is way, way different than when I started 40 years ago. And to succeed today as an independent office, not corporate, which is fine if you're corporate. I don't know if it's fine. It's not why I do these podcasts. How's that for truth? To be a fee-for-service practice, like most of you once dreamed of. In other words, is that a far-fetched dream for you? To simply put together a organization and a business based on a skill set that you trained for most of your life. 40 years of undergraduate, at least 40 years of graduate. And God knows, those of you that are specialists that went on for GPR trainings and all the CE that's really required as a part of being a Lionhearted dentist, God knows what the investment you've made. Is it so far-fetched to think that you just want to put out, I mean this, your own shingle with maybe your own office and perhaps a second office or whatever if you decide to, and charge and get paid commensurate with your skills and your commitment? Is that so crazy? No, it's not crazy at all. And that's what this podcast is dedicated to, that philosophy, for those of you checking it. Those of you that have listened recently know that I'm trying to mix some clinical with the overall picture of what it takes. And I'm going to do that today as well. I want to answer specifically some surgical questions I've been getting. And I know not all of you, by any stretch, are into just surgery. So I do want to tell you this. This is going to be the base of my podcast this week. Do you ever read, like I do, the numerous emails you get on the analytics around your productivity? Like what each chair should be producing. I mean, can you imagine thinking that? Like what your chair, if you have 3 chairs or 5 chairs, or if you work 8 hours, what you should be producing, or how much the hygienist should produce, and all these metrics and how to make it more productive. Do you understand that that's not where I'm coming from yet? And I don't even like to think like that, nor have I ever thought like that. And I'm going to make it easy for you, because the Lionhearted dentist, at least in my office, we don't have any production charts, but we do have cornerstones that we believe in, that we follow. And if you follow anything near what I'm going to lay out for you, it's just impossible not to have significant productivity. By the way, a Lionhearted dentist, you see this on my wrist right here? Those of you that are listening obviously can't see. It's a wristband because I was in a outpatient clinic this morning. And let me see the time. 2.5 hours ago, I was under propofol for a back procedure I had done. 2.5 hours ago. And now I'm here talking to you. Yeah, that's a Lionhearted. We follow that in everything we do. We don't cave when we have some trying, difficult things that happen in our life. I just thought that was ironic and I wanted to share it with you. So let's go. Let me not waste your time. So I told you, like, I almost get offended. Like, if you do this and do that, you should be producing $489 per hour. Really? I got to worry about that? I don't think so. This is what you need to do. And everything I've talked about for the last 2 years, you kind of need to simulate some of it for sure. But these are some central pieces that I want you to think about. I'm giving you this lately on your way to work, while you're doing your 30-minute treadmill this morning or whatever you're doing. Number one, it is a requisite that whether your staff is 3 people or 20 like mine, that every day requires that everybody brings their A game. We don't have the kind of practices that it's okay for half the people to show up and be ready to work. And I'm going to give you an exact example. And this is why. Because when everybody brings their A game, when the new patient or even the recall patient comes through your front door and you have an engaged front desk, in other words, somebody that is very aware that Mrs. Smith's coming back in today and she hasn't been in 18 months since COVID. Or that the new patient, Mr. Green, is arriving at 11 o'clock. They know that. And they're looking for them. Is that too much to ask? Or, when I called this morning for the appointment I just alluded to, just to find out, I think, where it was exactly or what was the protocol once I got there. This is what I heard. Good morning, mainline orthopedics. Hold, please. Seriously. Hold, please. You've heard this before. And maybe you think, I hope you don't. Maybe you think I'm being, oh my God, this guy just, nothing's enough for him. Me. No, that would never work for me. And it did happen to me this week. I called my other office and somebody didn't say hold. They just said Dr. Rasner's office, like that, and then blank. And I've taught my staff that the way I want my phones answered are Dr. Rasner's office, Stephanie speaking, how may I help you? I mean, is that really that much over the top to ask? That's a 3-line intro that engages the patient a little bit more and certainly is a lot better than what I heard this morning. So everybody needs their A game because it sets you up for one of the 2 things that happen weekly that lead to mass productivity. And one of the 2 things is your new patient experience. I'm telling you, it's not pie in the sky. It's not over the top the way I speak about what's required for a new... Remember, my new patients and many, many of yours are going out of network. And this is why this is so compelling right now. It is so compelling because here's what's happening, and I'm pretty sure I am spot on. What's happening right now is that the tidal wave of corporate dentistry is exploding at such a rate that more and more patients that were used to visiting Dr. such and such for so many years with a stable staff, and they always saw that doctor, and they were very comfortable with that personal relationship that they had established. What's happening now is that has disintegrated across our industry, which is not good for the patient, but is good for you and I if you aspire to the kind of practice you keep hearing me talk about. Because it's palpable, because they can feel the difference more easily, because there's less of these type of offices. So what I find happening, and I don't know because I don't never come on here and exaggerate, and give you more than I think it really is. But I've had this wave going on that you've heard me spoken of, particularly since January, that I don't know if it's a tipping point, but I've never been busier. And I keep setting records, record weeks, record months, record quarter. I'm being honest with you. I'm not telling you this because I'm trying to brag about it. I'm studying it, and I don't know if this is the new normal. But what I do hear from the patients that are coming in to us is exactly what I just said to you, is that their old doctor's gone. And in some cases he sold to corporate. In some cases he just checked out or sold just to another dentist. And they don't like the change. And so I'm getting more of a chance with these patients. So you're damn right. I want them to feel that everything counts the moment they walk in. You've heard me say it. It's spotlessly clean. Do I have a good vibe in the office? Seriously, are there coffee cups and half-open water bottles, disheveledness laying around on the very first stained-up glass door or windows? I bet you once a day I walk past my front desk separation between that part of the office and reception room. And as I walk past it on the way down the hallway, I'll say, somebody needs to clean the glass. We keep Windex, right? Everything counts to me. And I don't want to be saying that. I want my staff to understand that work results in a payoff of having a job that we all get to participate, including me, each week, which is, usually very morale uplifting, happy patients, new patients calling, not having to work evenings because we're not, for lack of a better way of saying this, we don't have to. We're working weekends, even really long hours. I mean, we wind it down. Our last patient is usually at 3 o'clock or 3:30, and that often just rolls into around 4:30 or 5 when we can all leave. They all went to a Philadelphia Phillies baseball game yesterday as a team because we can do nice things like that, or just like each other without pressure. So when you bring your A game to your doctor, it can't be sometimes. It's every day. And it's all of you. And I'm going to give you a great example of a breakdown in that and what I did about it. So I've had my hygiene team together, which consists of, I'd say I have 4 full-time hygiene members. And we've spent a lot of time with, you can imagine how I'll teach and implement what I want my office brand to be and how I want it to look. And one of the things was to be prepared for recall patients. Think about this for 1 second, guys. Has this happened to you? Have you been working and been called in to do a hygiene check, whatever you want to call it, recall, hygiene check, and when you went in there, you were caught off guard, meaning the hygienist told you the patient wanted you to look at such and such, and you didn't know the history of the bridge or the crown or the implant, meaning you didn't know what year it was done. You don't know whether you really recommended something else that the patient bypassed because either they couldn't afford it or they just didn't want to do the procedure that you recommended, and on and on. And then you make a mistake and you reschedule them for, that's not the mistake, maybe for what we'll call it a redo to fix the problem, and you maybe schedule that at no charge. And you're just caught off guard. You're unprepared. I think that's a very unspoken, gigantic part of an Achilles heel, what we do each day. Think about it. We have to get up X amount of times per day, leave what we're doing, walk into a room, and make decisions. Obviously, it's easy if everything's great. If you're like me, there are times when I am praying it's great. It's hard enough sometimes to get up and just even acknowledge the patient. It's a really hard part of what we do that nobody really talks about. And when you're in a heavy perio-pros restorative type of practice like mine, and like many of yours, where you, the doc, do a lot of outside procedures, maybe you do implants, or you certainly take teeth out, you graft bone, and you're doing these kind of things, and you don't remember the history. So I used to have my staff, my hygiene team, be spot on how important that was. And what I noticed in the last couple months that I've told you about, were even though we were record setting, I found myself at the end of the night rescheduling hygiene patients for a consult because I couldn't give them a recommendation because of what I just said to you. So I was really beside myself. I found myself waking up at 4 a.m. thinking about this. Why am I taking charts home more than ever and typing them and researching them? And I don't know the answers. And so I made 2 changes in my office that have already paid dividends. The first change I made was all new patients have to be seen by hygiene or by a person who can listen carefully when they're in that room with me and fully write up a chart or we type them, dictate a new patient a consultation verbatim of what I'm saying. Not everybody can do that. And I found myself doing that at the end of the night and going cray out of my mind because I didn't trust anybody else. And it's just not fair. The second part was, well, what about the people that are coming in? It's not even realistic, I don't think, for your hygiene team to come in early enough to thoroughly read charts like some of the ones both of us have, where there's a 20-year history. So here's what we did. We had a big meeting about it this week to decide how we're going to handle this. So when we have recall patients coming back into the practice, or any patient, so they're put in hygiene, that indicates something is wrong or they want it checked, it is the responsibility, we split it up between the front desk team and the hygiene team, to take that chart and outline chronologically the history of the area that we suspect there's a problem. So they would say, the bridge on the lower right is giving me a problem. So I would expect my team to go back. Was that bridge done by me originally? Was it ever redone? Did I recommend maybe removing it and doing an implant and the patient denied it? Maybe I re-cemented it. I can't remember this stuff, and probably most of you can't either. How are you going to know that in a 5 or 10 minute trip into hygiene? So, I have a saying that I always reiterate in my lectures, and that is, your team is only going to know what's important to you if you tell them what's important. And no, I did tell my team years ago how important those write-ups are, but you heard me use the words vigilant and due diligence to making this all happen because you, the owner, you're like me, you're the owner of your practice, right? So it is up to you to fix it as soon as you see a mistake or a breakdown in something, because you and I have the most to gain and the most to lose. And you can't feel sorry for yourself. Lions don't do that. You got to go after it, fix it, and then monitor it after you think you fixed it. Is it fixed? Like I'm telling you right now, it feels good what I did. I'll give you an update in 6 months if it's stuck. But I was at the point, and I think it's because I have so many cases that have gone on for so many years that of course things pop up. I need to know the history on them. So the takeaway here is that's part of bringing your A game. My hygiene team, which is exceptional clinically, stopped bringing their A game. Maybe except one of them. They just didn't do diligence to it. And they'd read up, incomplete notes that I couldn't make, that didn't happen, or have me ill prepared when I walked into the room. So now when that patient flows into the practice through a phone call or stops in to make an appointment, that chart, if is researched before the day of the appointment. And does that require time? You bet it does. That can't be all on you, doctor. It's not fair. The payoff for being in a practice like ours, where you're able to pay high fees to your staff, and you're able to set up a retirement plan. They're not automatic guarantees in every practice that exists. Or you have beautiful equipment, and you are proud that you work for a doctor who is on his game. I know it sounds like a lot, even as I'm saying it to you right now, to do all this, and quite frankly it is. And I've said this many times to you. It's only 4 days a week for most of us. And some days it feels overwhelming. This week I had a lot of challenging patients. We had a very good week clinically, but it was really hard. Not because I had so many patients, because I took on patients that many practices could not treat because they don't oral sedate like I do. And it was a lot of hard work by everyone, and I felt it. And to think that I would have to do all this research on top of that is unthinkable. I need help. I really need my team to step up where they can. I'm not nearly done with this. I'm going to continue these cornerstones, and I wanted to give you one clinical tip that I said I would give before I shut down. But so far I've talked about just bringing your A game, and there's 4 more things that if you do them, you don't need to have charts all over the place, and you don't need to do math and calculus to figure out which each room should produce, because it just works. I'm sure there came a time in Michael Jordan's career where he did not calculate and sit down how he was going to take a shot that went in. He did it. That happened to him. That was the outcome of a lot of preparation. Well, I'm giving you the prep, and I'll finish it next week. I got an email about what should you do with a sinus perf if you take a tooth out and there's a perf. It happens to all of us, right? So if the perf is less than 2 to 3 millimeters, there's really no need to worry. So think of that. That's a tiny little perf. I really don't think you need to get too excited about that. I certainly would put collar plug in. And I don't remember an incident in my long career where that became a problem. But let's assume the one that's a bigger tear than that. So there's a couple things that has to happen. I teach a technique called the 3-layer technique. So this is how that works. Over the tear, I will put a long-term membrane in the bottom of the socket. So usually what happens is you have bone, then you have part of the Schneerian membrane that you can see that's a little torn. So this memlock, which is a cross-linked long-term resorbable, so it lasts about 5 months. That you simply cut a small piece and drape it over into the socket. It's supported by bone, but it covers the tear. Then on top of that, I will put collar plug. So I call this the 3-layer technique. And then the 3rd layer is a non-resorbable cytoplastic membrane. I get them from Osteogenics. You want the single site. If you go on their site, they have videos and explanations of how to use it, but basically you are draping that from the buccal bone, so you have to release the tissue against the bone on the buccal and the lingual, because this has to drape 4 to 5 millimeters past the edge of the bone on each side. So the 3 layers are a cross-linked long-term membrane that's covering the hole initially. Secondly, a collaplug, bioplug, collagen of some sort. It also could be graft material if your tear is not gigantic. If you are staring into a 15 millimeter tear, which I know most of you aren't, then I'm not grafting that. But if it's less than, 8 millimeters, it's a little slit, I would still graft that. I'd put down the Memlock, put in the graft material of choice, which in my case is always 70-30, 70% mineralized bone, followed by 30% mixed in of xenograft. And there's reasons for that, and we can talk about that later. You can write to me. The xenograft slows down the turnover process. I don't want it to turn over too quickly. And then the top layer, which is a beautiful product, the dense PTFE, which is the osteogenic single site membrane. The beauty of that is we didn't have that a few years back. And you would have to get primary closure. You don't have to get primary closure if you're using that membrane on top. It can be exposed to the oral cavity. And that's the third top layer. And you leave that in for somewhere between 4 and 6 weeks. And when you take out that white membrane, it's not sewed in or tacked in or anything. It's tucked under your flap, or you don't even have to do a flap. You can just release the tissue with a Molt 2.4 elevator. I know this talk doesn't apply to all of you, but someone in particular asked me this, so I said I would do it. So here it is. And then you just remove it without even anesthesia 4 to 6 weeks later. And that has worked in 99%. I also put the patient on a augmentin regimen of antibiotics if I'm going to use the 3-layer technique. So I'm trying to mix a little clinical and management here. And we're going to pick up next week on what are the other cornerstones you need. And I'll add a little more clinical as well. What cornerstones you need so you don't have to worry about the minutia of tracking how much you produce out of a chair. To me, it's too much. See you next week on the Lionhearted. Thanks for tuning in.